Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, I'm talking with Lisa Allen. She has her bachelor's degree, RDMS, RDCS, RVT, FAIUM. She's an ultrasound coordinator, clinical instructor, clinical sonographer, and she is at SUNY Upstate Medical University. So Lisa has been a clinical sonographer and educator at the Regional Perinatal Center at the SUNY Upstate Medical University since 1992. She earned her Bachelor of Science degree from Rochester Institute of Technology, where in 2018, she received a Distinguished Alumna Award from the College of Health Science and Technology. Lisa has worked with the Society of Diagnostic Medical Sonography on the Continuing Medical Education Review Committee, the Advanced Practice Committee, and the National Certification Exam Review Task Force. She has served on numerous committees for the American Institute of Ultrasound and Medicine and has served 2 years as the second vice president for this organization. In 2015, Lisa received the AIUM Distinguished Sonographer Award. She has served the American Registry for Diagnostic Medical Sonography on the Obstetrics and Gynecology Exam Development Task Force and the Recertification Oversight Task Force Committee. Was a subject matter in fetal echocardiography and obstetrics and gynecology. Lisa has numerous publications on the prenatal diagnosis of congenital fetal anomalies. Please help me welcome Lisa Allen. Thank you, Lisa, for coming on and talking to our podcast audience. Today, the topic Lisa is going to be sharing with us is You, Me, and the CSP. I met Lisa at the RDMS conference and sat through this topic and got the tail end of a couple others that she spoke on and was just impressed with her research ability and her passion for finding something abnormal and then just diving in and going deep and then being willing to share it with the community. She's been a professor and she's spoken at RDMS multiple times. And so she has a heart of giving and wanting to share her information and what she's learned. And we're so grateful for people like you, Lisa, who are willing to give back to the community. And so hopefully we learned something new today. And I think this is important because as I travel, I've been asked to take this image a couple different ways, and so it's nice to have a reference or something that I could share with someone if they're open or curious enough to refer back to, and so we appreciate you sharing because I can use it in my own practice as I travel. So thanks for spending your time and energy just researching and preparing and getting this ready. I hope this helps a lot of our listeners. Just if nothing else, just review a little bit. But I used to take a still image of the CSP, and now I do a cine clip of the CSP. So it might change your practice in just a little bit of a way, and maybe not at all. But hopefully we'll be able to broaden your horizons a little bit with this talk. So first of all, Lisa, just tell us a little bit about you and your background and how you came to ultrasound and why you came to ultrasound, and go.
Okay.
Let's start that way.
All right. Well, thank you for having me and inviting me on. I appreciate the opportunity. So I went to Rochester Institute of Technology to get my bachelor's degree in diagnostic medical sonography. I've been practicing for a little over 35 years now. I started out at one of the local hospitals doing more general staff sonographer. So I got experience in OBGYN, abdomen, vascular, neurosonography, small parts. And I was there about 18 months and then was recruited by the Perinatal Center, which is a high-risk OB maternal fetal medicine center. And I've been there ever since. So I've been there a little over 32 years and just really focusing on high-risk OB. I am certified in OBGYN, abdomen, vascular, neuro, fetal echo. I think that's it. When fetal echo became a new certification, I believe it was back in 2006. As soon as it came out and became available, I pursued that as well because I do feel, as most of the professional organizations, you should be certified and registered in the field you're practicing in. And I had been working in high risk OB for so long in doing fetal hearts, but once the opportunity to actually hold the credential, I pursued that as well. So
Awesome.
with the Regional Perinatal Center where I work, I'm in New York State and we cover, I think it's 13 or 14 counties now in upstate New York and referral based. So it's basically all of the outlying counties will refer either for maternal or fetal high risk conditions. So we do see a lot of fetal anomalies and tend to follow them through the rest of their pregnancy. So I have a unique opportunity to see a lot of things that most people, that aren't in high risk OB don't get to see.
Yeah. Yeah. Which is kind of a special privilege to kind of walk through. I know earlier when we were talking, you were saying how you were able to walk through some things with some patients, and you really kind of do develop that special relationship with that patient during that period of time in their life with that certain situation. And I think that's one of the privileges that we
Right.
have as ultrasound people, is to kind of walk alongside them, just for this time. And then they deliver, and then they have other people who come along and walk alongside them, for,
Yes.
you know, early childhood development and different things like that. But for our piece, I think it's a special privilege to be able to do that.
Right.
So let's get started in talking about the cavum septum. I noticed in your talk, you started out by saying, what are the cavum septum pellucidai? Or is that how you pronounce it?
It can get very confusing because of like Latin and medical terminology. The cavum septi pellucidai is plural, and the septum pellucidum is singular, I believe. So in development, there's two leaves or lamina so the two of them are the septi pellucidai. And then later, either late in gestation or in adulthood, they fuse, and then it's septum pellucidum. So there's just one as opposed to the two lamina. So
Oh,
that's
okay.
why, and some people just it's called the CSP and one and done, and you don't have to
Yeah,
pronounce
one and done.
Latin
That's right.
terminology. Yeah.
Yeah. So I noticed that right away, and I thought, I'm going to ask her about that.
Yes. So with if you look at the diagram and if there's like a gross anatomy of a slice of a coronal slice of a brain, there should be the two lamina and then the cave or cavum, the fluid within the two walls. So that's what the cavum of the septi pellucidai. So the fluid inside is the cave, and the septi pellucidai are the two membranes or lamina that are on either side that form that rectangle anechoic box that we talk about.
Yes. Awesome. Um, so I think you first start out by talking about the absent CSP. right? And
Yeah.
how it's not very common, 3 in every 100,000. And when we don't see that, the kind of things that we can expect to see later with the scan or the development of the baby
Mhm.
and what they mean, right? So it can
Right.
be an isolated incident, or it can have some pretty severe indications, right?
Yes. Yes.
Yeah.
Yes.
And I think,
So, oh, go ahead. Well, I think for myself personally, because I had been scanning for so long, they update the protocols and the practice parameters per se. But when I was in school and I was doing your BPD and your HC, the CSP was not one of the landmarks that was included. So, as the resolutions gotten better and the equipment's gotten better, and perhaps our knowledge of neuroanatomy, fetal neuroanatomy, it became one of the landmarks. So I personally was not accustomed to doing that, my BPD and my HC. I was at the level of the thalami and the falx without the posterior fossa, like I knew the landmarks, but I wasn't trained necessarily to have that CSP in my BPD and HC images. And then, over the years, I realized that yes, it is supposed to be included. So therefore, if everybody, sonographers are learning in ultrasound school and they're learning for their boards and they're doing it in practice, and if they're doing the BPD and the HC at the correct level, it should include the CSP. Therefore, you are ruling out absence of the CSP in your normal standard imaging. It's not something you're going to search out. You're not looking for it in addition to other things. It should be present in that view as a landmark. Therefore, you're documenting it. And I don't think a lot of people realize that. And I don't think that there's just some confusion with the columns of the fornix and some other structures in the brain that it just takes a little bit more of encouragement and education so that you can recognize the CSP and hopefully not, miss absence of the CSP in the future once you practice and you really look at it.
yeah, because it is AIUM practice parameter for both the standard and for the detailed exam, right?
Correct.
And, like you said, it has been a part of our BPD and head circumference measurements as well.
Yes.
So it's important, right? We're looking for it often, right?
Absolutely. And I think one of the things that I guess I could put it back as to why I have like a passion for this particular topic, because with AIUM accreditation and just in any good practice, we follow up, do our postnatal follow-up. And so we have a mechanism in place that we are fortunate to be able to follow our babies to delivery and then get the outcomes after, if there's postnatal imaging, like a cranial ultrasound or neurosonogram after the baby's born, or perhaps an MRI. Some of our babies will have fetal MRIs to confirm the prenatal diagnosis. So as I was doing a lot of this, I was realizing that and that's what my talk at the SDMS kind of focused on toward the end when I presented the case studies, is they would be prenatally diagnosed with absence of the CSP. A few of them had fetal MRIs that confirmed that diagnosis. And then when it went on to have the babies born, either the information didn't get to the right place, so the baby was discharged without any imaging. The wrong terminology was used, and so in our practice, they were trying to put it in like the patient's problem list, but there's not an ICD-10 code for absence of the septi pellucidi, so they were sometimes had used a generic term like intracranial anomaly, but wasn't specific enough so that the people that are doing the postnatal imaging didn't know what to confirm or look for. On a couple of occasions, because they didn't know, they didn't have that specific code, so they used agenesis of the corpus callosum, which is not the same diagnosis. So that followed the baby, and then the baby would have the imaging, and they'd say, "Oh, the corpus callosum is present," end of story. So I had case after case where I went to do the postnatal follow-ups with the baby that was diagnosed with absence of the cavum septi pellucidi, by ultrasound prenatally, by a couple of them with MRIs, prenatally, fetal MRIs. And then when I went to do the follow-up, the babies had both neurosonograms and postnatal MRIs read as normal. And it was very frustrating. It was very concerning. And I'm still in the process of doing like a process improvement to follow through and work with the labor and delivery, the neonatal ICU or the regular baby nurseries, and also the imaging and radiology with our associated hospital, to follow this through to the end, make sure we're using the right terminology, make sure we're documenting it in the proper place, making sure that information gets to the hospital where they're going to be delivering, make sure that they know what the diagnosis is and we're using the right terms so that they can put it on the referral or the orders for that postnatal exam, so that they're looking at the right structure. And making sure, because some, as I've realized, and I've called around to some other departments, just try to see what other people are doing. And when they're doing the postnatal imaging and they're doing it on a newborn within day 1, 2, 3 of life, the assumption is they're ruling out intraventricular hemorrhage. So they're going to do that, and they're ruling out ventriculomegaly, and they're ruling out intraventricular hemorrhage, but they're not commenting on normal and abnormal anatomy. So you could have a structural anomaly, and that's not necessarily addressed because they think the indication is to rule out something else. So if the information is followed through, and then the postnatal imaging knows what they're supposed to look at and what they're documenting, and that some places will fall short, because if you look at perhaps the ICD-10 code for a neurosonogram, they're supposed to be documenting normal anatomy. So ultimately, and in a perfect world, the report would have all those structures. It would talk about the corpus callosum, whether it was present or absent or normal. It would talk about the posterior fossa, the cerebellum, the vermis, the cisterna magna. It would talk about and mention the ventricular system and all of those structures, including the CSP. And if that report was all inclusive and it did a checklist of all of those things within the brain that we should be documenting, then we would not be missing this, or as often, I should say. So I had several of these babies. I grabbed a couple of them while they were still in the hospital, still in the nursery, but most of them had gotten discharged with 2 exams saying had done both the postnatal imaging, the cranial ultrasound, and the MRI read as normal. So that's concerning, because as we're doing our QA and our pre and postnatal follow-up, if we've got patients that we diagnosed with absence of the CSP, and then they have 2 postnatal imaging modalities saying that it's normal or not addressed or not mentioned at all. Some of them said it was normal, some said it was present, some of them just didn't talk about it at all and said, the report, impression at the end was no evidence of intraventricular hemorrhage, but didn't mention any structures. One of the reports actually said, addressed it as I think it was a cavum callosum. It was a combination of the word cavum septi pellucidate and corpus callosum, because they're using terminology. And when I was in my talk at the SDMS, I was like, well, nobody has that, so they're lucky that they don't have it.
Right.
Because it was a combination of terms that weren't even correct. So that's where it really, for one, my talk at the SDMS was twofold. One, to educate sonographers about scanning the patient, documenting the CSP at the time of the anatomy scan. If you look through the talk, it should be present, and you should be able to see it in 100% of the patients between 18 and 37 weeks. If they're earlier than 18, you may or may not see it. 16, 17 weeks, I think it's up to 50 to 80% of patients you might be able to see it in. So if you're doing earlier anatomy, you will not or may not be able to document this structure. But once you're at 18 to 37, you should be able to 100% document it. So if you're not seeing it,
I think I've read,
sure, then say you don't see it. Be comfortable to say, I'm not really sure. I don't think I'm seeing it, because I think we're much better off having you say you don't see it and get further imaging or another follow-up exam than miss something. And a lot of the times that I've come across, that detailed anatomy, well, it can be your routine anatomy because it's included in your routine, but in your detailed as well, the patients usually have one. And once you clear certain structures and say that they're present, nobody's going to look again necessarily. You're not looking at all the anatomy again because the follow-ups are going to be for growth or for something else, or perhaps anatomy not seen. But if you're like, oh yeah, I saw it at 18, 19 weeks, it's not necessarily not just the CSP, but other structures as well. Somebody's not going to go and document them again because you said you saw them. With the
Right.
CSP, that's unique enough because if you're continuing on and doing growth studies, it should be in your image for your BPD and HC. So you should, keep it'll still be in your imaging and you would be documenting it. But in
Right.
other structures, I was working with one of my students today and I was telling her, I said, just anything, your picture of your, coronal face, and you said you saw the nose and lips. Nobody's going to necessarily look at that again because it is documented and checked off on that anatomy scan that it was seen and that it was normal. Then, and guess what? You missed, if you missed something, your imaging wasn't quite as good and the doctor signed off on it. And then the baby, subsequently somebody might pick it up later in gestation, or the baby's going to be born with a problem that was missed, unfortunately. So
Yeah,
between,
and I think it's important to remember, well, first, a couple things I wanted to speak to. I think I read a few studies that said the CSP is not fully developed until after 17 weeks. And
correct,
so, not trying to call something before it's really anatomically there is kind of important, right?
yes, yes,
But I think it's important that it's not just, I've heard other physicians even say, this isn't a one and done thing, right? Things are still developing in the baby. So it looked normal. I've scanned a baby that it looked normal at 20 weeks, and now we're 32 weeks and things aren't looking
right.
the same as what they did at
Mhm.
20 weeks, because as it develops, it gets bigger. The problem either presents itself more, or so that we're able to see it better, or yeah, it's not just a one and done
Right.
thing. So even on our growths, I'm not gonna review the whole baby, but I'm still paying attention, right?
Right.
uh,
Absolutely.
and if I'm doing pictures for them, I'm still paying attention to what that profile looks like, or that face, or those lips,
Hmm.
um so it's not just a kind of one and done kind of thing. You're still, even
Right.
doing a growth, having to pay attention to,
Hmm.
a lot of anatomy,
Hmm.
even though it's not required for us to document, you're still paying attention, I
Right.
think.
And I think with like you can create your own departmental protocol. So if you're doing a growth study, some places might do a head, a body, a leg bone, call it a day. We've tweaked our protocol over the years and included different things. And now, we obviously, like a sagittal lower uterine segment, documenting the position of the baby. If they're greater than 28 weeks, we'll do an amniotic fluid index, documenting the position of the placenta. We also do, and then we'll do two BPD, HC, AC, and FL. So two of each of those biometric parameters. And then we also document stomach, kidneys, bladder, situs, and ventricles. And then heart, for the heart views, we do the 4-chamber view, document a cardiac, the cardiac rate and rhythm, and usually throw on color real quick, because there's some things, as you say, they're progressive. So you're not going to necessarily pick them up at the anatomy scan. If it's a stenosis of one of the valves in the heart, it might,
Right.
it's very mild at the beginning and might not manifest until later in the second, third trimester. We've had, ventriculomegaly might not be
Right.
visible on the anatomy scan, but that could progress. Urinary tract dilation, some of those, genitourinary obstructions and some of the bowel obstructions, they're
Mhm.
not going to show up. Some of the cases of skeletal dysplasias might not, if they're not a severe lethal micromealic. So there's a lot of things that you can't say at their anatomy scan, and you did it between 18 and 22 weeks that everything looked good. it is worth that second look. And like you were saying, if I'm doing the growth study, I'm doing a quick sweep around and doing a quick survey of everything,
Right.
real quick, looking at, you point it out to the patient, but you're doing it as a checklist in your own, in your own mind, that everything continues to look good and that nothing's, jumping out at you that looks unusual. Because some of the things that I've detected were in the late second or third trimester. They weren't at the anatomy scan.
Yeah. 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 Pulmonary atresia. I myself or another colleague have found multiple times even. So a little particular about that.
Right.
Getting back to your talk, I do like your schematic that you shared. These are always helpful for me um, about the absent septum pellucidum. And if it's there and if it's not there, and then you kind of come down of, is there cleavage? Is there normal cleavage? Different things like that. And I think that's always helpful to kind of have around sometimes,
Right.
oh, okay, I'm not seeing it. Let me go to this book really quick and ask myself a few of these questions. Do I see this, this, and this? So that when I
Right.
do go to the doctor, um, you can really kind of, as you have been able to put it in your diagram, holoprosencephaly, I think, and schizencephaly, and even isolated agenesis, So
Right.
be able to tell the difference between a few of those things,
Right.
we can study it and we can know it, but then when it comes upon us, it's always helpful for me to have something to go back to remind myself,
Right. Yes.
So I appreciate that delineation there. Can you speak about those a little bit? And
Well, as I was doing my research for the actual presentation, found different nomograms or flow charts, shall we say. So, okay, you're not seeing it, and then, what to think of next, which direction, how are you going to work yourself through this? I think I had thought in the past when I was a newer sonographer that if you have agenesis of the corpus callosum, then you do have absence of the CSP. If you have that condition, the CSP is also absent. That's a given. However, you can have a normal corpus callosum in absence of the CSP. So a lot of people don't realize that. So if you're doing that sagittal midline scan and you see a normal corpus callosum, and you see the fluid between the corpus callosum and the columns of the fornix, that doesn't mean that you have a CSP. The fluid itself is not the cavum septi pellucidi. That's the fluid. But if you go in coronal, you're going to see those two leaves, and that separates the frontal horns. If you don't have a CSP, you're going to have communication between your frontal horns. And whether, if your corpus callosum is missing, then it kind of brings on a different appearance, but you can still have a normal corpus callosum, but in absence of the CSP. So then it's like, okay, what does that mean? Is that just a normal variant? Well, no, not necessarily. And that's when it comes to the flow charts and you look down and, okay, I have an CSP, or I have an absence of the CSP. Do I have a corpus callosum? Well, you can see the corpus callosum in coronal as the band of tissue that can, joins the left and right. However, the sagittal midline is going to be the view that's going to show the entire corpus callosum. And then you're going to want to turn on your color and look at the paracolossal artery. So if you're missing the cavum septi pellucidi, you're looking in sagittal to make sure that you have a corpus callosum. If you have a corpus callosum, that's great. Then it might be isolated. However, there are other things to consider about with the holoprosencephaly spectrum.
right.
As you may or may not know, some of the audience, that there's alobar, lobar, and semi-lobar. So alobar is clearly, you're not going to have a CSP. You're
Right.
not gonna have a corpus callosum. You're gonna have that's a very highly abnormal brain anatomy. If you
Right.
have the semi-lobar or lobar, you're going to have to some degree lobes, separation of the cerebral hemispheres, and you're going to have some of the anatomic structures, but in the lobar or semi-lobar, you're going to have communication between your frontal horns, but distinction of separate lateral horns of the ventricles. So then you have to get into, and some of the authors and some of the research has said that these are absence of the CSP in that frontal horns, the communication between the frontal horns is a form of holoprosencephaly, where others argue, whether it's cleavage and when the actual insult or abnormality started. But at any rate, that is something to consider, is the holoprosencephaly. And the other thing that we hadn't gotten to yet is septo-optic dysplasia. And that's one of the conditions, syndromes that is highly associated with absence of the cavum septi pellucidai. And there's more subtle things that we may or may not pick up, but schizencephaly, open and closed lip, things of that nature, porencephaly, other abnormalities that may be picked up in the brain that you can still have corpus callosum and a normal appearing corpus callosum and a normal appearing paracolossal artery, but you're missing your cavum septi pellucidai. You have to keep looking, and you have to look at all the structure, all the remainder of the structures in the brain, and really focus on that. Or obviously refer them out to a center that specializes in high risk OB and can do that imaging for you.
Yeah. Yeah, we had a case the other day that was a lobar, and so it was a good refresher to kind of review,
Right.
some of those things. And I think you kind of go through that hydrocephaly a little bit in your talk. I like your, and we'll share this presentation with your permission on the podcast. So if they have questions or want to see the diagrams and use this in their practice, they can, because there's just really good illustrations of the plane that you get certain things in. One image that really kind of stood out to me, because as a traveler, I was always taught to see the CSP as that box appearing structure, right, with the black fluid. But some of the physicians like to see the 3 white lines. But I think that is coming down almost too posterior, right? You're seeing the
Exactly.
roof.
If you see the 3 white lines, that's the columns of the fornix. It is
Right.
not the CSP.
Right. And so I've had a few discussions sometimes, not confrontation, but just trying to present some imaging of, that being the columns of the fornix as opposed to the CSP, right?
Right.
So I think that's really important to know, even first coming out, because if there are physicians out there who are saying, oh no, I need to see the 3 white lines, I'm like, really?
Yeah, so within that talk, and I don't know if I'm going to be able to, I can try to bring it up. You can still see me, but there's an article called Columns of the Fornix, Not to be Mistaken for the Cavum Septi Pellucidai on Prenatal Sonography.
Right.
And there is specifically an image in that they one of their figures, figure 1 in that particular article, that shows those 3 white lines and has arrows to it. It says the structures between the arrows were interpreted as a normal CSP, but they are the columns of the fornix.
Right.
So this particular article was addressing that, and then there was another article, and at one point it was one of the most downloaded articles from the Journal of Ultrasound in Medicine, the cavum septi pellucidai. Why is it important? And just to read off of this particular slide that I'm looking at from my presentation, it's required by the guidelines for multiple societies. So yes, why is it important? Because 1, you're required to take it and in a routine anatomy scan and a detailed anatomy scan. 2, its absence is a marker for agenesis of the corpus callosum, one of the most common CNS anomalies. 3, non-visualization of the CSP is often one of the only clues to the diagnosis of certain entities, particularly septo-optic dysplasia. And then 4, knowledge of the CSP provides an impetus to review and study other more obvious entities affecting the forebrain, such as holoprosencephaly spectrum, porencephaly, hydranencephaly, and severe hydrocephalus. So visualization of a normal CSP is a strong indicator of proper development of the central forebrain. So that was just something, to review, to go to those 2 articles in particular. Why is it important? And don't mistake it for the columns of the fornix. You can refer back to those articles or show them to your doctors, and maybe they just don't know, because I'm finding out a lot of people aren't educated on the structures. And they, even at, as I reviewed and gone through some of the imaging, even in our own center, if it's a newer sonographer that I go and look at and review the images later, or any of us, we can mistake it if you're not solid on that. You have to have those 2, in the transaxial plane, those 2 white lines with the rectangular shaped anechoic box. Otherwise, you can't clear it. And like, while you're imaging, it's just so important. It can be abnormal in shape if it's almost triangular in shape, or it's too wide or too short. A different shape to it also can indicate an abnormality, particularly partial agenesis of the corpus callosum. So there's a lot of, you have to keep training your eye to look for it over and over again when you're doing those BPD and HC images. What's normal, what's not normal? Do you have a cavum septa, cavum virgae, if the fluid extends past the columns of the fornix and you've got this larger space, which is considered a normal variant, but something to be aware of. So it's just recognizing the normal, documenting the normal. If you're not comfortable with it or don't think you can clear it, say so. Review it with other sonographers that might have more experience. Have somebody else come in and take a look. Hey, I'm not really seeing it. Could you come in and take a look for me? So that maybe you can clear it or get an answer one way or another before that patient leaves. Because you don't want to cause, of course, anybody any additional or undue anxiety for not seeing a structure. It's like you didn't see it because it's not there, or you didn't see it because of the imaging limitations. And it does cause, some undue stress if a patient gets an abnormal report, or a report of something they thought was there, and they find out 3 months later in their pregnancy that it's not present and it never was present. Some people, you don't want to miss it. You want to make sure you're documenting the structure.
Yeah. And, as we even talk through this, I think, even as a mother, not all of us are mothers, but when you are a mother, like knowing this ahead of time, right, before the baby's born, and being able to research and look up and be prepared for signs and symptoms that your baby may present.
Right.
These kind of issues, right? And so instead of going into a situation trying to figure things out, like, oh, I thought there was something kind of weird about this or that or the other, you can kind of go in already kind of knowing that there may be issues with this, that, or the other, without having to do all this searching and testing and postnatally. Right? Like, if we
some of that,
documented it and we've tested it with MRI and we're aware of it, then moving forward, that should carry a diagnosis with the baby or the child at the time, to help with developmental issues, as they grow and develop. And it takes a lot of guesswork out of that, on the after birth side of development, I think. And that can be really frustrating, especially for first-time moms who are still trying to figure out, well, is this normal? I don't know. As a first-time mom, I just remember just self-guessing all the time,
Yes, absolutely.
Or wondering, oh, is this normal? Okay, is that normal?
Right.
And so just knowing things ahead of time can help you prepare, help you choose a physician that may specialize in those kind of situations,
Mhm.
CNS abnormalities with your babies. And so it really kind of helps the patient go down a path that may be more helpful, and earlier intervention, as with
Mhm.
anything, is so much better than no intervention and having to backpedal a little bit, right?
Right.
So I think early intervention is the key, right?
Right.
And for this, diagnosis should go with the baby, and we should have like the MRIs and verify things, and they should know this when the baby's born, right? And that
Yes.
diagnosis should be carried on through the child's life so that they can help developmentally and get the right support that they need.
Yes.
Yeah.
Yes.
But
And
I
I
think
mean,
you're right. It's a very small structure that can look very abnormal. I've seen them wide, and people have called that normal, and I'm like, oh, just from years of experience, right? Of
right.
seeing abnormals and thinking, oh, if it's wide, I don't think that's it, um,
Mhm.
and different scenarios like that, right? It's
Right.
not your small box, it's wide or it's short, and it just looks different, right?
Yes.
By millimeters, right?
Correct.
So,
Yes.
so that's I don't know. I think it's an important structure that we sometimes can overlook at
Right.
times. So I think that's important.
Yes, and as you were just mentioning, like the size and the shape of it, of the anechoic box in between, if it's shorter and fatter, and there's no nomograms for the measurements and the length and the width and the height and whatnot, but can be associated with aneuploidy. So even if you have a CSP, but it's not the right shape or size, that's also, so when you're looking at it, not only looking to see if it's present, but seeing if it appears normal, like you were just saying, because the contour of the shape, if it's kind of triangular looking, then it can be associated with like partial agenesis of the corpus callosum. If it's really wide or big, it's can be associated with aneuploidy and some other conditions. So it is an important structure, and it shouldn't be. You really need to familiarize yourself with the normals and abnormal appearance of it. Do some research, look up some of those, perhaps some of the articles that I had thrown out there, the titles that, to make sure that that you get the correct diagnosis, and you're documenting it routinely in your exams.
Yeah. So talk to us. I know you presented a little bit about the cavum vergae. Can you talk
Yes.
to us about that and how that cavum septum uh can have an abnormal variant at times and what that
Yeah,
looks
so the
like?
cavum vergae is if the fluid within the cave or cavum is more prominent, so extends posteriorly past the columns of the fornix. So if you have the normal anechoic box, rectangle that you want to see up between the frontal horns, but if it seems to extend down further, um, in past the midline of the brain, and even more posteriorly, it's a more fluid-filled prominence, and it's called the cavum vergae. So the fluid in the cavum septi, between the cavum septi pellucidai, and then if it continues and it's more prominent and it goes past the columns of the fornix, it's called the cavum vergae. So in a sagittal midline, you'll just see a real prominent fluid-filled structure posterior to the corpus callosum, and it'll just extend differently. So there's the potential to intersect that. If you're doing kind of like a transaxial plane, you can catch some of the CSP in the front, and you can catch part of it in the back at the same time. And we've had people referred for a cyst in the brain when it's actually still, they're just intersecting the cavum septi pellucidae and the cavum virgae, the same structure and this fluid in the same structure in a plane that's catching it too at the same time. So it's just, it is a normal variant, to my knowledge, and I don't know this 100%, but it's not associated with any congenital anomalies or any other neuroanatomical abnormalities, but to be aware that that's what it is and that it's normal in it's called the cavum septi pellucidae and cavum virgae. And that term's used, it's a Latin term again, but normal, but to just throw it out there that that's what the diagnosis is. That's what you're visualizing. That's what what's in your imaging.
Yeah, that can throw you off sometimes, I think. So it's important to know about it. Tell us the importance of the paracolossal artery and why we take that view when we're trying to evaluate the absence of the CSP.
If you, the paracolossal artery isn't going to tell you anything about the CSP, but it will tell you about the corpus callosum. So if you are looking in your transaxial planes and your transthalamic and your BPD and HC level, and you don't think that you're seeing a CSP, or you don't think it's normal in shape or contour, you're just like something doesn't look right, then the next train of thought should be for you to go to a sagittal midline. And when you do your sagittal midline and you want to, because if your CSP doesn't look right, or if your CSP is absent, you want to rule out agenesis of the corpus callosum or partial agenesis of the corpus callosum. And to do that, you need to have a sagittal midline image. So if you get your sagittal midline image and you see the corpus callosum, that's great. But if it doesn't look, if it's not present, then you're going to not have a paracolossal artery. So, or your paracolossal artery is going to kind of float off in a different direction in that sunburst pattern, because it's not going to have a structure to follow around the anterior wall of. So if you're sagittal midline and you're scanning and you see what you think is an intact corpus callosum, you turn your color on and you want to see that paracolossal artery follow the corpus callosum in its entirety, not just up, because there's the different portions of the corpus callosum. So you're going to see the genu, the splenium, the rostrum, and the body. I don't know, I have to look in which order, but the different portions of it. But you can have the anterior and the portion, but dysplastic or absence of a portion of the posterior part of the corpus callosum. So you really, with that midline sagittal imaging, you will be able to look at the corpus callosum, then you turn on your color and document that paracolossal artery, and does it follow along that anterior wall of your corpus callosum, so that you can rule out additional, more subtle for sure, but other abnormalities. And I think with the, when you're doing the color Doppler on the paracolossal artery, to make sure that you have your color Doppler settings correctly, as in any, interrogating any structure with color Doppler, I tend to use what's called slow flow HD, which is really fine tuning it, and it will really light up, and you don't have to use a lot of adjustments. It's going to fill in that color for you without doubt that you have a paracolossal artery following. I've seen a lot of imaging where somebody's turning on the color and it's, there might be a little flash of a red and a blue right at the front of the corpus callosum. That is not showing you a paracolossal artery. That is showing blood flow in the brain, but it's not documenting a structure that you need to document. A vessel, blood vessel.
Yeah, and you also showed some reports coming back from MRI. So a lot of these cases are verified with another modality for confirmation. And so MRI is one of the most common.
That's correct.
Or the only one used, really, to verify these kind of and just support our diagnosis. But even in their reports, sometimes that CSP, their communication with the anatomy is lacking at times. And so I think the follow through and the follow up that we are able to do is really helpful for all modalities, right?
Yes.
And it's a good check and balance system. And so I think that's really important to do that follow-up. I also want to just mention, because you had mentioned it earlier, I want to like second the motion of making sure that you see that color along that whole roof of that corpus callosum, and not just some flash that comes up, to the anterior part of it. Because like you said, you're seeing different parts of that, and you're wanting to be able to interrogate the whole artery and not just part of it.
Right.
So I second that motion and want to say, yeah, making sure that that artery is the full length of that
Right.
corpus callosum.
Right.
I
And I
used
do
to
think,
get
oh, go ahead.
upset that they would send them for MRI. Well, we'll just verify with MRI. And I'm like, what do you mean verify it? Didn't I verify it? Like, how clear?
I
You can't get any
understand.
more clear than what I've just shown you and what I gave you.
Exactly.
But it's just added information for the physicians and for the parents to
Yes.
confirm. And it does give another view and another way of looking at it. And like you said, ultrasound is operator dependent, and we sometimes get fooled and different, not as much anymore because our technology has gotten so much better. And I think our education is coming along as well.
Yeah.
But yeah, it's nice to have another modality kind of complement our diagnosis, but
Right.
making sure that they're commenting about it, right? Like some
Yes.
just walk right on past it without making the comment of the no CSP.
Right. Well, I think that also, I mean, that goes for even OB ultrasound. I've read reports from numerous OB private offices. Some don't use like a reporting app or reporting package, and they might just type up their own. Or what they do, the information that's provided in the anatomy scan, there's a lot of structures that aren't even addressed or mentioned that are components of a routine anatomy scan they should be doing, and there's no mention of them whatsoever. So you don't know if they're present, they're not present. Did they look at them? Did they image them? So that's
Right.
why it's very difficult for us or any facility when you're getting the patient the second time. You can't go by anybody else's work. Like, you can't take it for that they saw all this stuff, because you don't know what their protocol is. You don't know the experience of the other sonographer, or how good their equipment is, who the reading physician, whether it be a radiologist, an OB, an MFM, because the sonographer could have documented it in the images. They could have put it in their, documented things correctly, and the physician could have taken it out. The
Yeah.
physician is ultimately responsible for the content of that report. And
Right.
they add things and they can take things out, and whether or not your image is documented or don't document it, that final report may or may not be what you thought you were seeing as a sonographer. And that's the way it is. So as long
Yeah.
as you have images and you have documented them and you've labeled things to the best of your ability, because once you've ended that exam, and at most places, I'm assuming, have like a PAC system of some sort, that they are archived. The images, the DICOM images are archived. They're there. They're not going anywhere. So as long as you've documented, regardless of what that report ends up saying, you did your job. And unfortunately, the end report does not reflect the exam sometimes, or what's documented in the exam, whether it be a OB prenatal ultrasound or the postnatal MRI or the CT or the X-ray, or any imaging modality. It doesn't always match what the images show, or they're not looking at the same thing that you were looking at prenatally, or they're not documenting each and every structure that should be documented in a postnatal brain imaging, whether it's the cranial ultrasound or the MRI or a CT. Every single structure that's included in that, if you look at the coding, and in order to bill for that particular exam, you're supposed to be looking at XYZ and reporting on it and documenting on it. And if you're only saying the ventricular system looks normal and there's no evidence of intraventricular hemorrhage or ventriculomegaly in your head ultrasounds, and you're missing a structure, like the brain is
Yeah.
literally missing a midline structure, that's pretty scary. That's
Yeah.
something that we
Yeah.
need to work on by obviously educating and maybe changing the protocols, making if you don't already have a protocol that has a checklist that goes down all the different anatomic structures. I know some places use, and maybe you're familiar with this, Debbie, because the like carbon copy of the baby, and you mark off all the parts you saw, and then half the slip or the carbon copy goes to the floor perhaps, or back to L&D, and then
Uh-huh.
the other one, the physician sees it to read the exam. But something similar to that for the brain, and having all of the different structures within the brain. Did you CSP, corpus callosum, paracolossal artery, cisterna magna, cerebellum, cerebellar vermis, and all the different, ventricles, and some without measurements, whether you have to do the color or don't do the color, but establishing a departmental protocol that addresses, so you're not missing anything, and that with due diligence for that baby and their family and their diagnosis, and get them, like you say, on the right track. If there is something wrong, then they can get early intervention, then they can have the testing, then they can be referred to specialists or have the appropriate care to give them the optimal, outcome for whatever the condition may be.
Right. Yeah, and I think in traveling, I think what I have been experiencing lately is that we're even starting to fill out the impressions, at least the preliminary impressions anyway. It's like a drop down choice, right? And
Yes,
so then we can add our comments as far as our thoughts in regard
yes,
to any specific um anatomy structure, right? And
yes. I would
so I
only,
think it's important to remember that yes, the doctor is ultimately responsible, but if we're, putting in some preliminary comments, that we make sure that we put in that we weren't sure that we saw this structure or that structure, or a lot of times with dilated kidneys, I'm always adding, I was not able to see dilated ureters,
mhm,
like, and no cyst in the bladder,
mhm,
like, just added information, um,
right,
to assist the doctor. And I mean, I can't imagine, we're seeing what, 8 to 12 patients a day, and they're seeing 30,
right,
and
right.
so I do think it's important for us to make sure those reports are correct.
Yes. I would just caution that the impression section is reserved for physicians. So, because that, in to be careful, because diagnosis is, there's a difference between the sonographer's scope of practice, and we cannot diagnose,
Right,
but we kind of do. We
right,
know what's going on. We've spent an hour with this patient. We've taken images in every plane possible. We've Dopplered it. We know, obviously, and we're the ones that have to take the appropriate images and then document things appropriately. Or perhaps if you're going over and presenting in front of a radiologist, I don't know if that's old school now, because there's teleradiography, where you might not physically have a radiologist or somebody reading your films on site, or your digital images or whatnot. In some of the experience I've had in people that I've run into, the radiologist isn't even in your same state. They're reading from
right,
another state, archive, or accessing the images from somewhere else. So that it's even more important that you are accurate, and you have taken all the images you can, from every possible angle, labeled things appropriately. If you're not comfortable with it, either say you don't see it, or get somebody in, a second set of eyes, because it might be the only chance to do that anatomy scan. But
right,
I'm like struggled with the same thing that you're saying, Debbie, because if I try to describe it in the best I can, but I put it in the comments section, that they can change, but the impression is that's the portion of the report. And I had to research this at one point in time, not, medical imaging reports, not just ultrasound reports. In imaging report, the impression is reserved for the physician. That's where they put the findings, the diagnosis, differential diagnosis, follow up if they want to follow up in 2 weeks, management, anything like that. That's the section for them that a sonographer should not necessarily be documenting in the impression section, but should, in the comment section, we have an internal comment section where we can put stuff that doesn't go in the final report, but it's a mechanism within our reporting system to communicate with whoever's reading the films. Hey, look at image 24, 25, and 26. I thought that this looked a little, something.
Right.
Or, if you can't get them on the phone, if you can't present to them in person and have that discussion, you need a place to describe and help them to get to the correct diagnosis and have that report be complete and address everything. And we struggle with what we, the limits of what we can and can't do as sonographers, but you want that report to come out as complete and as informative as possible. So it is a tricky thing.
Yeah. Yeah. So some just take home points is kind of what you ended your talk with. And it's everything that we've talked about, like cannot see the CSP until 18 to 37 weeks. I think if I recall right, after the baby's born, the CSP kind of disappears. Is that correct?
If you're scanning them in the first few weeks of life, it would still be there, but eventually it's supposed to fuse and you would not see it in adult life. There are some studies out there when they've done brain imaging, and if you still do see the CSP, the two leaves of that there's association with schizophrenia and some other conditions. So yeah, so but yes, it's supposed to fuse and not be visualized later in adulthood.
Yeah, so that was interesting for me to learn when I was kind of doing some of my own research on it at the time as well. Just remembering the columns of the fornix are the 3 white lines, not going too posterior to make sure that you're kind of up above that, or the third ventricle. That the cavum does not communicate with the ventricle system. And it should be visualized the mid-sagittal plane and the transaxial plane and the coronal plane. Do you routinely document that in all 3 planes?
No. If you've documented the CSP in the transaxial plane, like the BPDHC level, that's where we're documenting it. And if you've documented it and you're comfortable with it, you're done.
Right.
In the mid-sagittal plane, to just to clarify, you can document the corpus callosum, but you cannot document the CSP. The mid-sagittal plane, you're going to see the fluid there, but that does not show you whether or not a CSP is present.
Right.
So it's going to be the transaxial and the coronal that you'll see the CSP.
Yes. Yeah. I think that's important to differentiate as well. Yeah. And then just remembering that we get an MRI when they're pregnant, but also postnatally, I think they're done as well. And it's real challenging for our physicians when they see this to really know how to counsel patients, right? Because the spectrum of disabilities are so wide, right?
Correct.
So, this is the plus and minus of finding problems earlier, right? We can kind of give you a heads up that there's an issue. We don't know how bad the issue is going to be, right?
Right.
So I think that's important to keep in mind, that there's this huge range of disabilities that can come with this, and where they land on that spectrum is not something that we can ever tell prenatally, right?
Correct.
And just making sure that it's part of our protocol, that it's a very important part of the requirements for our scanning, and having good communication, with your other colleagues and physicians, so that if there is any concern, you can always say, I think that's the beauty of scanning in a location where there's other sonographers, as opposed to like scanning in a private doctor's office where you're the only one,
Right.
and you don't really have someone to bounce things off of. And so if you are in that type of situation, please feel free to reach out to me or to Lisa or to someone,
Sure.
just for a second opinion, or someone else that you know from ultrasound school or that might be in high risk OB and has run across these kind of situations before. We don't ever want you to feel like you're out there alone. There's a couple situations that I've worked where I've been the only one. And even after 28 years, it's like, man, I'd like to have another set of eyes on this,
Mhm. Yes.
So it's kind of our safety net to have other colleagues around us, so if you don't have that, please feel free to reach out and contact somebody that may have some more knowledge about this topic, and just get us another opinion, shoot a picture to somebody and say, what do you think? Or a clip of something, and use your resources of finding a friend, to help you in your endeavor. Well, thanks
Right.
again, Lisa.
Oh, you're
We
welcome.
definitely appreciate this act of kindness and preparing and sharing. And I hope that I know that this will help some people who are listening to really just put a keener eye on that CSP and evaluate it a little bit better. So thank you.
Oh, you're welcome.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.